HIV, hepatitis, and TB prevention and control in the time of COVID. Then we have Dr. James Hinrichs from St. Louis. He will be talking about the St. Louis County COVID-19 pandemic response and how some of the tools and innovations that they implemented during the response could be adapted for STDs, TB, and other communicable diseases and partner services going forward. And lastly, we have Lacey Malevy from Colorado Department of Public Health, who will be talking about web-based partner service interviews and also demoing the tool that they use. And then, as I said, we'll complete with the group discussion and Q&A. So without further ado, I'm going to stop sharing my screen and let Thomas Bertrand share his screen and present for us.
Okay. Okay, can you see my screen, Allie? And hear me?
Yes. Yep.
Okay, great. Okay, I'll proceed. First of all, thank you to Allie and Janine for inviting me to present today. I know this is an informal group. I see a lot of friends on the call. Look forward to the conversation. My goal is just to give a brief overview about our experiences in Rhode Island and the Rhode Island Department of Health in 2020 to current about responding to HIV, STDs, tuberculosis, and hepatitis during a time of COVID. So just a little background on Rhode Island. Some people aren't familiar with this state. We are the smallest state, 37 by 47 miles, which does impact our ability to be very responsive in terms of geography of meeting the people who are priority populations. Our nickname's the Ocean State. We have 400 miles of coastline. Some notable first, we had the State Health Laboratory, the first circus, the first 4th of July parade, the first synagogue, schoolhouse, and we're the birthplace of the American Industrial Revolution. We have about a population of 1 million people. That ranks us 42 nationally. So there are 8 states with fewer population. And we are fairly diverse, 81% white, 12% Hispanic, and 6% Black and African American. In terms of the Department of Health, our director is Dr. Nicole Alexander Scott. She's an ID specialist with a background in adolescent health and HIV. She's a great champion of ours. We have a centralized public health system. So our responsibilities are both at the local and state levels, which compound some of the work that we do, but we're very much on the front lines. I am the chief of the Center for HIV, STDs, Tuberculosis, and Hepatitis. And so we're very integrated. We have a relatively small program and we're organizationally organized by function. And pretty much everyone in the program touches each one of these diseases, which is good. And then finally, we have a really strong internal collaboration with our family planning and overdose prevention program. So probably not a surprise to all of you, but just to share with you insights of what was in the background of 2020 for us. First of all, burnout. We had staff reassignments, a lot of burnout and morale challenges that continued to linger. Remote work, clearly, we actually had a COVID exposure in our TB program, which was out for 2 weeks. So that kind of kicked off us all working remotely as much as possible. We had unspent dollars in 2020 because so many of our staff were assigned to COVID and we had unspent personnel dollars that we're working on right now. Clearly, and of course, the public health focus was on COVID in terms of resources and fiscal and PAP personnel, which impacted us to perform our jobs. Ongoing syndemics, overdose deaths are rising. A lot of attention is on the syndemics related to drug user health. And we only saw rates of HIV and STDs have a modest decline between 15 to 20%. So we still had a job to do and a lot of work to do. It's not as though the number of reported HIV and STDs went away. If there's anyone on the hepatitis program from the CDC, they still required a competitive major grant that had to be submitted, which consumed about a month of our work. And then finally, the practical aspects of this is our work and the work of our community organizations had to respect social distancing requirements. So that really made us rethink a lot of the work we're doing. And that's what I wanted to go over with you today. I did want to give you a quick snapshot. These columns represent months back to March of 2020, and the rows are staff. And if there's a red block, that means that they were assigned to COVID. And so as you can see, the first 3 months of 2020, every single one of our staff members were assigned to COVID. Our program basically was suspended. And through today, we have people who are still out, maternity leave, any number of challenges in terms of staffing. But we still try to be innovative and responsive. And I'm just going to go through 6 or 7 interventions that we've worked on just to highlight them. And hopefully down the road, we can all talk more about some of the work that's going on in the States. So first of all, with the help of the Delaware Department of Health and our great colleagues there, we thought we'd start a condoms by mail program. They provide a lot of guidance and technical assistance. We called it Mask It Up, Wrap It Up, an online program, and developed an online ordering system using technology. We get about 60 requests per month. We had many of our CBOs that were part of our community condom distribution program had suspended all their availability. So this is the only way that many people who couldn't afford or access condoms could get them. We had 1,573 requests to date. We give out 15 condoms per request. And again, thanks to Delaware. And this is a program I think we might be reaching people who we might not otherwise be. Another big component of our program, as I mentioned, overdose deaths and drug user health, a huge priority in the state. AIDS Care Ocean State is the organization we subcontract out to. They came up with the idea to start doing home delivered services. Again, this is a benefit from a small state, but I think we are the only state in the country where anywhere you live, if you can request home delivered services and get them within a day. And that includes the staff showing up at your doorstep, literally with naloxone, rapid HIV and Hep C test kits, condoms, clean needles, and needle disposals. So during 2020, we gave out 160,000 needles. We had 807 unique clients and 186 home deliveries. So again, meeting people where they're at and increasing access and reducing barriers. Another big launch for us is our drug user health vending machine program. In short, we learned a lot from Las Vegas on this. In Puerto Rico, I believe Chicago, and I think Cincinnati has started to go in this direction. And these are basically vending machines that individuals who are people who inject drugs can access certain supplies. I wanted to show this picture to give you a feel of what the vending machine looks like. This is the one in Las Vegas. Notice to the left though, it's their sharps container disposal with it, which is going to be our approach also. And the supplies can vary. The goal is to get out naloxone. We'll also be giving clean needles out, condoms, early pregnancy tests, Nicorette gum, and try and be as client-centered as possible for people who inject drugs and what their needs are. You can buy these machines and they can have a Wi-Fi capacity to actually track utilization by individuals who use codes to access them and how much supplies are in the machine so we know when to resupply them. We're kind of excited about this. We're calling it a statewide program. We're gonna have 6 installed by July 1st. It includes a motel off of Motel 6 off of Route 95, which are big interstate, a homeless shelter for men, our syringe services program site, a community health center, a pharmacy, and we're also coordinating with the prison in Rhode Island in women's and men's upon discharge that the individuals can get access to machine. They will not have needles though. They'll have naloxone and other supplies. Another adjustment for us was offering our HIV Hep C rapid testing class, which we already had some modules online that people would take before coming to the in-person class, but we adapted it and have it all online right now, along with a module on COVID and doing HIV and Hep C rapid testing during COVID. We shared this with some of our other New England states, and I think it's been very helpful. We also adopted an at-home rapid HIV testing program with one of our agencies, AIDS Project Rhode Island. They wanted an organic state-based program. I know there are some national options out there, but they want to adapt it specifically to us. Again, using technology, an online portal where you could register, learn more about the test, and then get pre-test counseling, either through a phone or email. And during 2020, we had 277 tests, 2 positives. As an outcome of their relationship building, we get results on 94% of people who actually take the test, which is really incredible. And we're reaching a really good target group. 66% of our clients are MSM and 44% in the 20s. On the TB front, not always something we talk about in our field of STD, but what helped us survive during the year was a program called EMOCHA Health. It's an online service software that we share with our TB clinic, a clinical site, where our clients who are on DOT access software and take videos of themselves actually taking their medication, clicking on side effects and other information and submitting that to us. And in an effort for us to reduce our visits to clients, this has been really important and something that strengthened our program in 2020. Another piece that we had before COVID was an app that the health department created. It's a sexual health app called Right Time, RI being for Rhode Island. It has a lot of information and resources of where to get condoms and family planning, sexual assault prevention. And it also has a function for letting partners know that anonymously if they were exposed to an STD. That's a locked function unless that we give to a provider when they diagnose somebody, they can use that. But very high activity in 2020. We had 645 downloads, 5,600 sessions. And just recently, I'm getting a lot of requests from providers to access the internet partner piece of it. And then finally, rather than go the direction of at-home HIV, or excuse me, STD testing, we developed a system called Testing 123. It's basically an online system where you can access a portal, fill out some forms, select a clinical site, excuse me, a clinical laboratory site where you can get blood drawn and urine for testing for HIV, STDs, excuse me, HIV, chlamydia, gonorrhea, and syphilis. We'll send an order, a lab slip signed by our medical director, Dr. Phil Chan, to the site. You just show up. You have to have insurance and be asymptomatic. The results get sent back to the STD clinic and we call people if they're positive. So an easier way reduces number of visits to the STD clinic and other sites and lets people be in control of getting tested. And we call it Testing 123. These are the two steps. Just launched this 2 weeks ago. We've had 2 successful people go through the process and we'll be doing a big launch later. And then finally, in terms of future considerations, things that are on my mind at the moment is that novel and innovative public health interventions are definitely being developed at the state and local level. This is where it's happening. I'm learning from my colleagues, both at the health department and in the field, about how to develop meaningful programs. I think peer-to-peer learning needs to be prioritized, like number 1, both regionally and nationally. Just want to shout out Delaware and Las Vegas, provide us invaluable help. And we have an STD, a New England consortium that meets. And again, my partners there have been fantastic. Adaptations to programs have resulted in wider reach to high priority populations. And obviously it's enhanced through the use of technology. And also, and this is a much larger conversation around the need to apply what we've learned to the federal GIS Workforce Development Initiative that's rolling out. I just want to note, I do not have a slide on partner services. If I could be frank amongst friends, 2020 was a complete disaster for us when it came to partner services. While cases only modestly dropped, we had staff leaving to COVID. We had other staff leave for retirement. We had to reduce the number of interviews we were doing. Some feedback I've gotten from my staff saying that many of our index cases who are now very familiar with what contact tracing is through the media and COVID are very resistant to provide names. And it's a new skill level for them to develop relationships, develop the trust, and have people share contacts. So again, I think we all need to talk about this and figure out what's the best training for us in the future so we can have a really robust GIS response in the future. This is just a picture of the staff. Couldn't be done with all of us, but we're a great group and a terrific team. And if people have any questions, feel free to reach out to me. And thank you again, Jeanine and Ali, for the opportunity to present. And that will conclude what I have to say.
Thank you so much, Tom. And at the end, we will be fielding questions either through the chat or you may unmute your mic. So hold tight. And if you have questions for Tom, we will get to that at the end. And so next we will have Dr. James Hinrichs, an infectious disease advisor, and he will be presenting about innovations, opportunities to improve response to STIs, TB, communicable diseases. And he's from St. Louis. So Dr. Hinrichs, it's all yours.
Thank you so much. Thanks for the opportunity to speak to this group. I'm relatively new to public health. I'm infectious disease practitioner for 40 years and then made the mistake of volunteering for the county last May to help with contact tracing. And they asked me to come in for an interview, which I thought was strange. And the next day they offered me a full-time job. So it turned out that St. Louis County's communicable disease section was basically run by a veterinarian. And we had one physician in the group who was just out on maternity leave. So there was an acting medical CMO, there was an unfilled chief of the department. And then I came on board and we tried to hire some other people. So it's been an interesting saga for the last year. I saw a lot of STIs and had an HIV clinic in my practice life, but discovered that St. Louis County has a very active STI clinic and a TB clinic, but most of the DIS and contact tracing was done by the state because there was a period of time where St. Louis County and St. Louis City were not doing a very good job with this, and the state basically took it over. So I still don't have an active involvement with that, but I hope to learn some of the lessons we've gotten in terms of our COVID response and perhaps interest some of our good case investigators that have been trained with COVID to basically pivot a little bit and maybe become DIS people with the STI clinic and the TB clinic and expand our ability to do a better job in St. Louis County and St. Louis City, where we have a contract as well. So, so my next slide, basically, let's see, I don't know if I can, oh, okay. So this describes probably a familiar scene to all of you in terms of the COVID outbreak. When I came on board in the middle of May, at that point, they were basically using file folders to keep track of cases. Our first case in the St. Louis area was about March 8th of 2020. And then we then pivoted before I started to using RedCap, a Vanderbilt University product, to do our case investigation as well as our contact tracing. And as you can see, after Memorial Day, as with many parts of the country, we had a big surge in the St. Louis area and then a huge surge in October, November, December, and January. And by this time, we had put out flyers to try to get volunteer contact tracers enrolled. We had a lot of temporary employees that came on board. And basically the logistics of that, just pertinent to what the previous speaker had said about having to work from home. So we had to get phones to them, we had to get laptops to them, train them on contact tracing, et cetera. But by the time they were fully on board, we hit the second surge and we were getting about 1,000 cases a day in St. Louis County. So it was very difficult to really get to that period of time. So everything really evolved as far as our ability to respond to the pandemic. And as you can see, our numbers more recently are about a week old now, but very, very good trends in our case load at the present time. So if I could have the next slide. So as I said, March 8th was our first reported case in the St. Louis area. We had a very rapid rise in cases as the rest of the country with long-term care facilities. The St. Louis County was scrambling to help nursing homes with PPE, get their protocols going, testing going, and all the Department of Public Health staff were really all reassigned to COVID response, as in Rhode Island. And then we had a call out for volunteers, part-time employment, temp bases. We had a very rapid ramp up of training resources such as the Johns Hopkins course with mainly a work at home main option. We used Basecamp as a platform to allow contact tracers to communicate with team leads, which we had to develop. So all of these people kind of came on board on a very rapid ramp up program. As I said, we went then to REDCap as our database, which has served us fairly well, but we're sort of with about 100,000 cases in there now. It's starting to max out as far as its ability to handle our needs. And the next slide, please. So what, and it's interesting, I've been spending a lot of time over the last couple of weeks looking at the website for this committee, which really has done terrific work, it sounds like, over the last several years. And I think we've kind of learned some of the same lessons with what we've used as far as technology for particularly for the surges, in order to meet the demands for getting to these cases. So a lot of our innovations basically were to try to totally ramp up our educational platform on our website, which is stlcorona.com, and basically to help the community partners to engage when they find out they're positive with their family members, with their contacts, and try to do as much work for us as they could to educate their families in terms of safe practices, et cetera. So that was really a necessity during the surge when we could only maybe reach 100 to 150 people at the most each day with our staff, which was part-time and sometimes strained, particularly on weekends, et cetera. So we also went out and actively asked for participation of local school nurses, educators, a lot of university leaders in the St. Louis area, Wash U, St. Louis U, really to let us partner with them in terms of their contact tracing and their release from isolation. Part of our stay-at-home order and our legal authority as a county public health department was we were the sole function of being able to release somebody from isolation. So we had to get letters to them, try to get their emails to get that to them or through the mail. But we gradually, as the surge expanded, we let private physicians pick up that capacity as well. We started using mass texting, which I think is something that was very familiar to this group. We have a RAVE system, which was primarily used as an emergency system, but we had a license for that. So we started mass texting to positive cases, basically to alert them that we knew about their testing, but mainly to point them to the website to help us with their household contacts, with getting a hold of their contacts and notifying us if they were reluctant to take care of their contacts so that we could intervene at that time. We also put together a pilot project where one of our physicians that I recruited to help, a very analytic-based guy, started a pilot project to text cases that we had a phone number just prior to phoning them by one of the case investigators. And we then, after we had some success with that, we did a full program with that in order to really dramatically improve the probability that the case investigators would get the phone call picked up. And this was something that we're probably going to publish in a public health journal in terms of, a fairly dramatic 20% increase in the uptake just by text messaging people right before the phone calls. Since everybody was working from home, it's difficult for people to know what number is going to call them. We tried various things to try to have it show up as the Department of Public Health, but we're unsuccessful in that. So text messaging really did help us get to people and have them pick up and respond to the case investigators. With that, we were able to obviously reach 100, 150 a day by text messaging and had 60 or 70% pickup in terms of being able to finish the case investigation. And the next slide, please. So the educational resources, I think, are an important part of what we did just to have more active participation in the county with their treatment as well as follow-up. So application to other communicable disease as we go forward. Obviously, I think we want to pick up on the smartphone technology that you all are using so much, but using that as an adjunct to improve our communication and alert contacts with the need for further communication as well. This certainly should facilitate partner services in this regard. And then we have a large staff now of about, up to 50 people that are either part-time or team leads, et cetera, whose work is probably going to go away as time goes on. And we're trying to actively utilize them, people that have an interest in STI and HIV, to train them as intervention disease experts to help us as we hopefully start taking more of the syphilis, gonorrhea cases to heart, as well as HIV contact tracing. Some of the vaccination innovations and success in COVID vaccine, obviously, I think can really strengthen our ability to improve our vaccination efforts with such as HPV and hepatitis vaccination down the road as well. So I think although we have not been as active with DIS in terms of our HIV and STI clinic as well as our TB clinic, I do think that we have a huge potential with some of the well-trained people that have gone through the COVID epidemic to express an interest in expanding their bandwidth and perhaps creating a much stronger Department of Public Health for St. Louis County. The next slide, please. And I thank you very much. This is my contact information, and I respect all of you for all you do. I know DIS is certainly a different animal than COVID case investigation and contact tracing, but I hope to learn more from you all and apply that as we expand our footprint here in the county. Thank you so much.
And thank you, Dr. Henrik. Our final presenter is Lacey Molevi, and she will be discussing web-based partner service interviews. And we are going to be lucky enough to actually see this in action or an example. But if you have any questions, please put it in the chat, and I will be reading them after this final presentation. So any questions in the chat, and then also we can open up the mics after. Thank you. And Lacey, it's all yours.
Thank you. Good afternoon. My name is Lacey Molevi, and I am the Partner Services, otherwise known as DIS, Supervisor for the Colorado Department of Public Health and Environment. And I wanted today to discuss our web-based interview platform that we developed for our partner services. So we actually developed this platform before COVID, but it wasn't until fairly recently where the acceptance rate picked up among both our DIS and our clients. I definitely want to point out that we don't think that this is a replacement of face-to-face or telephone interviews. I think those are always going to be the best alternative. That's the best way to build client rapport. But we do know that we had to be creative and find a way to reach clients that may be resistant to the traditional partner service interviews, and also just figure out a way, we also had DIS that were deployed, which meant we had less time to spend with each client. We wanted to continue to be able to still investigate all of our HIV cases and all of our syphilis cases. So we wanted to find another way that could kind of help fill in the gaps while we were short staffed during this time. Next slide, please. So I am going to briefly go over what our goals were for this pilot project, as well as talk about the platform that we used. And then I'm going to walk you through the process on how the DIS offered the web-based interview to the clients, and then finally wrap that up with a live demonstration of the platform. Next slide. All right, so here were our overarching goals. Is we did want to be able to increase the percentage of clients interviewed. Again, this was our last ditch effort for clients that refused telephone or in person, but we wanted to be able to increase the number of individuals who were being interviewed by DIS. We wanted to improve the time frame for an interview from the date of diagnosis. We were hopeful that this would help us to increase the number of contacts per case interviewed. I will say, not super successful in eliciting partners through this, but we were very, very successful in obtaining additional referrals for these clients. And I'll talk a little bit more about that when I go through the demonstration. We also thought that this would be a way to improve completeness of core data variables that are required for CDC and HRSA. So again, this is data that would not have been collected with the client refusing a partner services interview, but we were able to obtain some additional core variables when they completed the web-based interview. And then finally, as I had just mentioned, we also thought that this would help increase the number of referrals to HIV medical care, to our state drug assistance program, increase STI HIV testing and treatment, as well as some PrEP referrals. Next slide. So the platform that we chose, which I believe probably many of you on the call are familiar with, is the Research Electronic Data Capture, which is REDCap. We chose this because it's a secure web application for building and managing online surveys and databases. It also provided us the ability to make this interview available in both English and Spanish. And so this also was a good choice for us because we were already using REDCap pretty widespread in our department. So we're using it currently to track and monitor HIV and Hep C testing done in the community. We also use it for PrEP navigation and linkage, as well as our home-based HIV testing and our data collection for the SURGE project. Next slide. Okay, so I'm going to walk you kind of real briefly through the process of offering the web-based interview to clients. So step one, of course, is that the DIS are going to exhaust all of their attempts to conduct the interview either in person or by phone. If the client refuses to meet with us or talk to us by phone, that is when the DIS will then try to offer the client a web-based interview as the last attempt for engagement. Currently, we were allowing DIS to use this for all HIV cases, syphilis cases, and any cases with someone who was previously living with HIV and was co-diagnosed with another STI. So this is just a sample script of, a text or maybe a voicemail that the DIS would leave with the client. They would just say, if you would prefer not to discuss this matter with me, I can send you a link to a survey where you can answer all of my questions on your own time. And then they just ask if they'd be willing to complete a secure online survey. So we do not send out the survey by text or email unless the client agrees to it. So I just wanted to point that out as well. That's part of our protocol. Next slide. And then so step two, the client would accept the web-based interview either from the DIS verbally or by text. And so at that time, we would just say, great, thank you. Would you like to receive the link by email or by text? And then they will receive it within the next 5 to 10 minutes. And we just ask them to complete it as soon as possible and to reach out with any questions. Definitely acknowledge that the major drawback to this is it only applies to individuals who have either a phone or a computer and internet access. So we have been looking into more creative ways that potentially having a tablet available at some of the clinics that we work really closely with, and would they be able to have the client complete the survey, after they meet with them, either for a treatment visit or however we could potentially insert it into there. So we are trying to be more creative so that we can have this reach, more people. Next slide. So then step three is after the client agrees to a web-based interview, the DIS is actually going to log into REDCap and they're going to create the new record and they're going to enter the PRISM ID. They'll enter the client's name. They'll enter their name since they're the DIS worker. And then they'll either put in the phone number or the email in which the REDCap will deliver the survey to. Next slide. So then the client will receive the link again by email or text, and they'll simply click on it. And this is just an example of what that email or text will look like. We definitely want to try and be very vague in our messaging because we don't know who could potentially come across that text message or that email, but just letting them know that they've recently have spoken to someone at the health department and they indicated that they wanted to complete the online survey. And then we provide good contact information if they have any questions while they're completing the survey. Next slide. And then, so finally, this is kind of the wrap up of it all. The DIS who was assigned the case, who sent out the REDCap link, they'll be notified by REDCap that their client has gone on and completed the survey. So at that time, the DIS will go into REDCap, and unfortunately at this time, they have to manually enter any of the interview results into Prism. In the future, we would love for Prism and REDCap to talk a little bit better, but for this project, just because it is kind of still in its pilot phase, we have not done that merging quite yet. So it does require a manual transfer. But then in Prism, DIS will actually select under interview type, we'll select web-based interview. And this has allowed for us to be able to better evaluate the program so we can, report on partner index and all of the referrals that are being made based off of our web-based interview. And then finally, the expectation is that the DIS will go through and any referrals that the client had requested, whether it be for PrEP, HIV linkage to care, partner notification, they'll go in and initiate those referrals and conduct the partner elicitation at that time. Next slide. All right, so here's the fun part. I'm gonna walk you guys through just kind of what it looks like for the client. So I'm gonna share my screen here. And if you can just confirm that you can see this.
Yeah.
We can't see you. Was it, you said yes, correct?
Yes, yeah, those of us,
okay.
Yeah, yep.
All right, so.
Could you maybe talk a little through what you're doing for those that are called in? Okay.
Yep, so this is where we'll start with them. This is our disclosure statement. So it's just making sure that they acknowledge that they have agreed to take the interview online. And then this is where they could select whether or not they wanted to do it in English or Spanish. So we would click on that. And then this is just saying that they accept the terms and conditions. So we'll go for there. Okay, and so we first dive into the demographic section, and we wanted to make sure that we were explaining to clients why we were asking the questions that we were asking, right? And so this is just letting them know that we're asking some of these demographic questions to help us better understand cultural and societal barriers, which could affect our clients' health. And so this is just letting them know that by providing these answers, we can better develop and deliver appropriate services. So you'll see that there's sex assigned at birth, and they have, for every question that we ask, they have the option to decline. The system doesn't require them to answer a question that they don't feel comfortable answering. So we'll have sex assigned at birth, current gender identity. I'm just gonna kind of click on things as we move along. Do you think of yourself as, and so they do their sexual orientation. And if they want to for other, they can certainly type in and be specific with that. And then it will ask them about their race as well as their ethnicity. And so we'll just go here. And then it goes on to the medical section. So letting them know that the purpose is to complete accurate and medical information is to help foster quality and continuity of care. So it's just letting them know that this helps us with their health status for preventative health services, treatment, planning, and delivery of care. So we'll ask them, why did you recently receive an HIV test? So they could say, routine testing, experiencing symptoms, anything that they would like to do. So let's say that they just do routine. It will ask if they've had any signs or symptoms. So we list all of the signs or symptoms that they could potentially put. And this is to help us, of course, with potential staging of syphilis, if they're mentioning a body rash or hair loss, really just to help us collect additional information. And then if they also, it asks if they tested positive for syphilis, we have a little bit of our ocular and neuro questions going on. So asking them if they had blurred vision, vision loss, flashing lights and all of that. If they do select that they've had a symptom, it will have another question generated that will ask, when did these symptoms appear? Are these symptoms ongoing? Okay. Whoops. So I'll just put today. And then it will ask, have they ever tested positive for an STI? If they say yes, it'll be, if they say no, there's no drop down. If they say yes, it's gonna ask them to specify which STIs they've had in the past. And then it will also ask them about their HIV status. So it just says, you know, am I currently living with HIV? I was just diagnosed with HIV. I do not know my HIV status, or I'm not living with HIV. And each one of these will generate a different drop down. So let's, for example, say they say I'm currently living with HIV. This is when we start to get into any referrals that they might need. So it's asking if they're currently visiting with a primary doctor to keep track of how they're doing with HIV. It asks if they're currently enrolled into STAP. And so what you can see is if they say no, they can say like, no, I am not enrolled. And then it can ask if they want someone to contact them. They can say yes or no. It's totally up to them. So let's just say they say, yes, I do want someone to share more information with me. And then we go on to the sexual and social. So again, really stressing confidentiality here with them, letting them know that this just helps, again, provide additional referrals if there's anything that's indicated in the interview. So we talk about gender of sex partners, types of sexual contact that they've had, any potential other risk factors such as, you know, meeting partners online, injection drug use. And then if they do say that they have injected drugs in the last 12 months, it'll ask them if they want a referral to the syringe access program. So they can say that, yes, please go ahead, or no, I don't wish to be connected at this time. And then finally, at the very last section is the partner notification section. So this is letting them know, again, just really stressing that we can help confidentially and anonymously notify their sex partners. And then just talking about the importance of why you want to notify your partners. We also, again, talk about HIPAA, and again, letting them know that partner information can never be given out. We just thought that this was really crucial because, you know, that's a big part of the in-person and telephone that you're having with the client, is you really have to stress the confidentiality nature of partner elicitation. And so we tried to make known several times within this interview template. So anyways, they have the option of 3 things. They can say, I have already contacted my partners. So if they do, it just says, great. Please remember that although you notify them, sometimes they may still need help finding a testing location or access to free testing treatment. If you would like help, select yes up above, okay? If they say yes, or I'm gonna actually skip down here. If they say, I have not contacted my partners, but I prefer to do it on my own, this is when we let them know there's multiple ways that you can notify your partner, but we also refer them to the tellyourpartner.org so that they have another option of notification if they think they're going to do it, but then ultimately aren't able to do it. And then finally, there is the yes, please help me confidentially and anonymously notify my partners. So we'll just go with that one. And what we do here is it will ask, you know, name, it just says fill out as much as you can. Partial names are okay. The more information you have, the better. So we have name, phone number, email, age, date of birth, city and state, identifying descriptors, type of sex that they had with that partner so that we can make sure that that partner is getting all of that, you know, the triple site testing or whatever testing they may need that's applicable to them. And then talking about last sexual contact so that we know if their partners need any sort of preventative treatment. And then all they would do is they would simply fill this out. And if they wanted to add additional partners, they just get another page that looks exactly like this, or they can then submit it. And then it just says, you know, you have consented to receive additional follow-up. So again, this would be if they said they wanted more PrEP information or said they wanted someone to help link them to STAP, then they could go ahead and say, this is how I want to be notified. And they can either put in call only, email only, text only, and they have the option to put in that information. And that is the survey. And I can stop sharing.
Lacey, thank you so much. We have a few minutes left and we have several questions in the chat, and mostly it's about your presentation. So I'm going to ask those. And then after that, if we have time, or if you want to stay on and ask questions aloud, you can do that as well. So the first question that I have is, are there any other programs that you're aware of that, or anybody on this call is aware of, that use web-based partner service interview forms? And the person that wrote this says they know about Houston used to do this through Houston Pens, but not sure if they are still doing it.
So shout out to Houston, because that is actually who originally, where we got this idea from. They had done a presentation and we were so excited about it that we did reach out to them, got some lessons learned from them. I don't know if they're still doing it, and I don't know if there's someone on Houston that can speak of that. In regards to our department, we, our communicable disease, so the foodborne illnesses, are also using REDCap to collect some data as well and do their investigations.
Great, and we can go to our next question, which are, what reasons are patients given for refusing in-person or phone interviews?
Sorry. So one reason that's been declined from us is, well, we do notice that a lot of our younger population, this is more appealing to do the web-based interview, which is not super surprising to me since they like to do all the texting and not so much phone calls. This was also easier when we stopped doing like home field visits. We also stopped going into clinics to do those face-to-face interviews. So this was another substitute for it. But if clients are refusing to do a phone interview or an in-person interview with us, but accept the web-based interview, a lot of time it just has to deal with them saying that they can't talk to us during normal hours. And we do try to, accommodate. I have my DIS that are so willing to work on, evenings and weekends to try and get that interview in. But what we've noticed is that a lot of people are completing these interviews at very off hours. And so I think it's just working better with their schedules as well to complete it.
Okay, and then we have another question from the chat, and that is, can you share a PDF or a list of the questions you ask in the survey? And if that's okay and you'd like to share, you can send it to us, part of the UTASP, or to the listserv. But so the first question is, can you share? And then the second question is, this would be useful for us in the future. Also, do you have any trouble getting approval from your HIPAA officer to do these surveys?
So first question is, yes, I can certainly share the questions that we ask. It's actually done in a really nice format. So as you could see, when I was clicking on a lot of those questions, there were various different drop-down options that would be generated. So the kind of the cheat sheet form that I can share with you all does have all of those various different drop-downs and skip logic. So it's going to be a beast of a document to look at, but it will kind of show you and highlight everything that they can select in the different drop-downs. In regards to, getting approval and, from our security officer that we could use this, luckily, REDCap is HIPAA compliant and very, very secure. And our communicable disease staff had kind of already paved the way for us of getting it approved. So we didn't face any challenges in being able to move this forward.
Okay, and the next question is, did your partner contacts increase as a result of the web-based application?
No, so I did allude to that in the beginning of the presentation to be a completely open book. I do not view this platform as being very successful with obtaining partners. I would view it, definitely more successful to collect those core data variables that we have to submit, but then also to generate those additional referrals. There were definitely people that expressed prep interest or, help getting connected to a medical provider, but just not so much the partner piece.
Okay, thank you. And then there was a question for Dr. Hinrichs, and this is, do you think the RAFE system could be adapted and acceptable for STD positive cases?
Yeah, definitely. I think it works out very well because it's a secure system as well. And you can send out just at the drop of a hat 150 phone calls. So we batched it so that we would start sending out maybe 50 at 9 o'clock, and then another 50 or so at 1 p.m., and then another 50 right before we closed to give because the case investigators worked through the evenings. So that allowed people that were home from work to sign in. So yeah, it's a good system for that. And it's a lot less tedious than trying to do it all manually.
Thank you. I'm just checking through to see if there are other questions. And if you have, it looks like that may be it. We've gotten a couple of feedback that DIS, of course, Rock are wonderful. And are there any questions on the line? And if so, you can unmute your line and just ask the question.
Hello, can you hear me?
Yes, we can hear you.
Okay, my name is Shannon Harris and I work at DHEC in South Carolina. I'm currently a prep coordinator, but I used to be a DIS in the Midlands in South Carolina. So my question is when asking about signs and symptoms when it pertaining to, say, for example, syphilis, most of the time I've noticed the client didn't even know that they had a symptom. Say, for instance, if they had a bump on their vaginal area, they thought, oh, this was just a hair bump. Or if they had got the rash on their body or something, oh, I have eczema, because of course, you know, it eventually goes away. So when asking about signs and symptoms, you know, that's how we base off identifying our partners as well. How does that kind of work, especially if they don't know if that was a symptom of syphilis and not just a eczema versus a rash? Do you understand my question? I know I said a lot.
So are you asking more so like how do we determine like an interview period of when we're asking them, or like partner information, how many months we're asking them?
Right, when how far to go back versus, you know, when you're asking about their symptoms and stuff like that, because that's what we kind of based it off to when pertaining to the partners.
That's an excellent question, Shannon, because I think that was the most difficult part of our entire survey for us is we, you know, and not even to just that point, but what if we were sending this to somebody who was diagnosed with gonorrhea and then, you know, latent syphilis, two very different interview periods when you're, you know, notifying people. And so we didn't think that the system would be smart enough to kind of capture and then default to an interview period. So when we ask about the partner piece, the note above it actually just defaults to a 12-month time period.
Okay. Okay. Getting everybody within that 12-month time. Okay,
yeah,
that's good. Because at that point, you still are able to maybe catch it and stop the spread of the disease.
Exactly.
Okay.
And we do ask, you know, again, in the partner piece, we ask, you know, have you had sex with this partner in the last 60 days or last 90 days? And that is specifically so that, you know, if we know it's a primary case of syphilis, or if it's, you know, a chlamydia or a gonorrhea, it can kind of help us filter out those partner notifications too.
Mm-hmm. Okay, well, thank you.
Thank you, Shannon. Are there any other questions on the line or anything else you'd like to discuss? I know we're coming to the top of the hour. Just any final questions? And if your question hasn't been answered, please, you can still submit it through the chat or through an email.
This is Rachel Kotcher from CDC. I had a question for Tom Bertrand about the vending machines, because this is something that we've thought about adopting for HIV and STD testing. And so I wanted to, you may have told us how much the vending machines cost, but I was wondering how much they cost. And then do you think they would be successful for things like at-home test kits, condom distribution, those types of things that are more sexual health focused rather than drug use focused?
Oh, yeah. Yeah. Hi, Rachel. Thanks. This is Tom. I know Katie Howe, my colleague, is on the call. The machines themselves cost, I think, around $8,000 to $10,000. And you can customize them in terms of where supplies go and the size and how they fall out of the machines. There's kind of a design and engineering piece to it. Yeah, and all, just to let you know, we do see these as sexual health machines too, that will have condoms in all of them and possibly like safe sex kits with lube. So that's definitely a possibility. We haven't planned to have HIV test kits in there. They're fairly expensive to put in the machines, but we're going to be including information in the machines if you want an HIV test, how to access it, either through one of our HIV testing sites or our mailing program. But we haven't planned initially to use machines for rapid HIV or Hep C testing.
Great, thank you. It looks like Jen Howell says Southern Nevada uses them and provides self-collected test kits, which is great, especially given costs.
Cool.
I also wanted to definitely encourage Jim to publish your pilot project on texting cases. We always need that information published to help provide the support for using technology for things like partner services. And I feel like it's such an amazing response and such an easy lift to send out a text to somebody that you're about to call that I absolutely would encourage the publishing and other programs to adopt it as well. And I know Alicia mentioned you could also use Google Voice and Text to do this as well. So it seems like it's a pretty no-brainer all around.
Thank you, Rachel. So our colleagues at NCSD included a link in the chat for an evaluation. So please go ahead and click that link. You'll also receive it in an email, and we will be sharing this presentation to the listserv the way that we sent out the invite for this meeting. And if you have any future ideas or discussion topics that you'd like to discuss, please email. You can see on the slide that Ali and myself are the most direct people you can reach, but you can actually email any of the contact people on that list. And I want to thank the presenters today for the presentations. They were wonderful. And if you have any questions, and we also plan on sharing the presentations themselves, the slides, as long as we get approval. So that should be coming as well. Thank you everybody for your time and also for the presentations. And have a nice day.
Thanks, everyone.
Thank you. Bye, everyone.